Welcome to Forward Physio, the show that gives you high-quality information about injury and rehabilitation, performance, and health. My name is Noah Mandel, and I'm a resident physiotherapist from Toronto, Canada. I created this podcast to provide you with educational content, not medical advice. Please seek advice from a qualified healthcare professional if you are currently dealing with a health-related concern. If you enjoyed the podcast, please consider leaving a review. I would deeply appreciate it, and you would also be doing your part in helping the podcast grow so that we could provide this information to more and more people. Hey everyone, welcome back. Today we have one of my favorite episodes to date. We have none other than Erik Meira on the podcast. If you know Erik, and that's why you're listening to this podcast, I'm sure you're already pretty excited to listen to it because Erik is one of the best thinkers in the world of physiotherapy, at least in my opinion. Erik goes by the Science PT because the principles and philosophy of science underpin a lot of what he does in practice. He's very well known for his critical thinking skills and for his ability to take a step back and look at issues from different lenses. We cover a lot in this episode, and it's going to be very difficult to pick a few clips to post on Instagram afterwards because there was just a lot of really valuable stuff that Erik said today. We talk about how Erik is doubling as a pilot, the foundations of science, whether physiotherapy is more of an art than a science. We talk about psychology. We talk about why lasers are nonsense. We discuss Plato, Socrates, Newton, and Aristotle. And we also discuss why leg extensions likely aren't bad for someone after an ACL reconstruction, and much, much more. Without further ado, here is my conversation with Erik. All right, Erik, thank you again for joining me. I really appreciate it. It's an honor having you after having listened to so many hours of you on a podcast. It's nice to finally have you on mine. So I'm really looking forward to today.
Thanks, Noah. I appreciate the opportunity to chat with you. So this will be fun.
Yeah. Before we get started, do you want to give a little bit of an introduction to everybody? Who are you? What are you about? And what's a little bit about you that's not so related to PT?
Yeah, so my name is Erik Meira. I've been a physical therapist for 25 or so years. I'm run the learning platform known as the Science PT, which is thesciencept.com. And as you mentioned, I had started the podcast PT Inquest, which is actually my second physical therapy podcast. PT Podcast was the first one, which I think was pretty much the first podcast related to physical therapy practice back in, I want to say 2011 is when we started that. What I do now is mostly I work with, as far as my practice, I'm mostly working with high-level athletes, collegiate and professional in a number of different sports, mostly basketball and soccer, some football, some volleyball, those types of things as well. But my main thing is doing education around physical therapy practice and clinical critical thinking, complexity of movement, those types of things, physics, lots and lots of physics. As far as outside of physical therapy, kind of the other thing I do is I've recently become a pilot. So I do a good bit of flying and actually working on developing an education platform for people wanting to become pilots. Wow. And working on getting the approval to build an online ground school. So teaching people basically the didactics that they have to do. Because in order to become a pilot, you have to pass a written test first, proving that you understand the concepts around flight, safety, radio communication, all that stuff. So, going to build that out hopefully in the next year or so.
Yeah. It's very cool. What made you want to become a pilot?
I've always been, ever since I was a little kid, I've always geeked out about flying. And that was actually the career I thought I was going to do. But, there's a very strong go to college thing, which, to become a pilot, you don't have to go to college. You just got to go through the training process. A lot of them do go to college, but and for me, it was just a matter of I don't know. I wanted to get further in my education, and then that kind of took me away from flying. And eventually, I kept talking about getting my pilot's license, and then finally, my wife, as a present, basically was like, "I've set aside the money. Go to flight school. Do it." And so, about 2 years ago, I got started on that. And so I'm still doing my own education, but it's all on the actual flying side of things. It's not on the ground school side of things. And the cool thing is you can be a ground instructor. You don't have to be a pilot to be a ground instructor, because it's just teaching the concepts, and all that you're doing is preparing somebody for the written exams that are associated with becoming a private pilot, an instrument rated pilot, and or a commercial pilot. Those are the ones that have those written exams that are based around ground schools.
So cool. It's, obviously so different from PT, but I guess the common thread here is that you're still very into education. Has that always been a passion of yours?
Yeah. My mom was a teacher, and I love sharing things that I've learned. And it makes me typically very boring at parties, but it fits a very specific niche professionally. And there actually is some interesting overlap, I think, between aviation and physical therapy practice, because it's a lot of physics. You're calculating moment arms and that kind of stuff when you fly. Like, you have to make sure your plane is weighted appropriately and in balance, so that you can so that the plane isn't fighting you if you go into a stall. But then also the critical thinking. So they have a whole thing known as cockpit crew resource management, or single pilot resource management, where you're going through your processes of how are you validating what you're seeing? How do you actually go through your process of making sure your perceptions don't get the best of you? Because that's how people die in plane crashes, is typically they think one thing is going on, but something else. And so there's all these like systems that you have to learn about, checking yourself, going back, making sure you're not in some sort of a mental spiral where you're blocking out all the other information coming at you. So it's a lot of that kind of teaching. And the really cool thing is, so for example, when there's a plane crash, here in the United States, the NTSB and the FAA are the regulating bodies. They do an investigation. It's two separate bodies that do their own independent investigations. And let's say they determine that it was pilot error that caused the crash. They don't stop there and say, we're just going to blame the pilot. The whole point is, no, the pilot shouldn't be able to make that error. So what was it that made that pilot make that error? Is it a problem with their process? Is there something we can put on the panel that will be alerting the pilot better to the mistakes that they're making, to make sure? Because it's not just a matter of finding out what the cause was. It's trying to figure out what is the way to make it never happen again to another pilot in another plane, and then obviously other passengers. And that's why there hasn't been a fatal plane crash in the United States, at least since I think 2014 was the last one. So no, sorry. Like 2000. No, I think it was 2014. Yeah, it was the Asiana flight that happened in San Francisco. But anyway.
So this is
way off tangent.
It's all good. So there is a common thread here, and this is why I wanted to have you on the podcast, because I feel like that process of going over the mistakes and thinking about why you're doing things, and how mistakes are being made, and sort of just taking a step back and really looking at the why and the how we do things. It doesn't happen that often in physio. And I think a lot of people are just sort of, they're in clinic, people get better, whether that's due to time or placebo or whatever. And because of that, they're not really forced with needing to critically evaluate themselves a lot of the time. So people just sort of get by.
Yeah, and what it is, a big problem that we have in that type of setting is that it's a low stakes feedback. So you see a patient and they get better, and what we know, basic things like natural history and regression of the mean are basic concepts. That means when somebody comes in to see you, they're usually going to be at their worst That's why they're coming to see you. It's like something is going wrong, and they're at the point they're like, all right, I need to see somebody. And so they get in to see you. And so automatically they're at a situation where they're going to, natural history cures a lot of things. We've been getting injured for millions of years, literally, along with all the other animals getting injured, and even plants. And nature finds a way to get you better, but maybe not perfectly. And the kind of our job is to try to get you better than what nature would have done automatically. But we have a really hard time of understanding what nature would have done automatically. Mm. And then the other thing is this idea of regression to the mean, meaning, whether you get a high or a low, you're always going to settle back to whatever your mean was. So if you come in a really bad state, you're going to kind of come back up to that. So with that working against your critical thinking, so what if you do, quote unquote, the wrong treatment? As long as your treatment doesn't keep them from getting better, your treatment could even be slowing them down. Right. As long as they got better, you think your treatment is the thing that did it. So what's the harm, so to speak? What's the feedback telling you, that what you did is wrong? And so like in aviation, if you do something wrong, significantly wrong, you get a lot of great feedback as to how that went wrong, assuming you survive it. And so this is where, surgeons are another example. I give the example of like a spine surgeon. We talk about like landmarks. Where is L4? Well, I'm going to base it on these landmarks, find where L4 is. And so there you are, and you do your intervention. What's the harm in you being at the wrong level? Right. If you're doing some manual therapy thing, there's no big deal for you as a physical therapist or physio. But for an orthopedic surgeon, they laugh at the idea of using landmarks to say this is L4. They're like, no. Because if they start an incision and they're actually at L3, that's a huge problem, that they've done that. So they have to use what's known as a spinal needle, which is they actually stick this little needle into your spine while you're, under anesthesia. And then they take an X-ray, and the X-ray shows them where they actually are, because it actually matters to them. And so that's the thing, is we have so much kind of low stakes feedback that it makes it really easy just to kind of go along your day and get absolutely no feedback to help correct you.
So science is the process of really refining this whole feedback issue, right? It's how we go about, improving and making sure that we aren't making mistakes. But if it is so low stakes, is it really important to get this feedback in physical therapy? So my question to you, Erik, is first off, what is science, and why is it so important in PT, especially if a lot of the time, patients will still get better?
Yeah. So science, the simple definition is science is the search for objective truth. Contrast that with subjective truth, which would be, your thoughts and opinions and your own personal filter for things. And so like the way you see something could be different from the way I see something. It would actually have to be different. And so, what science is trying to do is remove all of that subjectivity to get at what is actually going on in nature. I think it was Ernst Rutherford that said, all science is physics and stamp collecting. So meaning that, physics is the only pure science, because it's straight up objective. Like, whether you're talking about, classical mechanics or even like quantum mechanics and relativistic stuff and all these other things, that's the hard science with all the hard math to it. So math would be like the purest expression. Mm-hmm. And so, obviously there are subjective things going on and with our patients and all these other things. And so science doesn't throw all that out. What science says is that's something different that it's not talking about. And so like when you ask, what does an intervention do physically to somebody? That would be more of a scientific question. When you get into saying, okay, well, it doesn't do that, so therefore it may do all these other things. That's then, okay, what are all the subjective interactions that feed into this effect and all of that? And that can be looked at scientifically, but what you're getting at is like population trends and probabilities and these types of things. So you see, there's just tons of uncertainties where you kind of end up end up heading with that. And so it's kind of this embracing of uncertainty. And so now, why does that matter for physical therapy practice? Well, if you know what your treatment does and how it works, so to speak, and all the ways that somebody could be presenting, then it allows you to focus in on what is specifically effective about what you're doing. So an example here would be, let's say somebody has patellofemoral pain and you're going to do some sort of exercise intervention. Let's keep it as kind of standard, classic standard of practice here. I'm not going to get into any manual therapy or taping or any of these other interventions that you can do, but let's just talk about an exercise intervention for it. And so what you're looking at is, the easiest way to define patellofemoral pain is this is somebody who has an anterior knee load tolerance issue. They do not tolerate the load required for their day-to-day activities as it goes through the patellofemoral joint. Now, lots of things can be contributing to that. So we know that it could be like structural. So for example, the structures, the tissues of the patellofemoral joint may be sensitized. They could be damaged in some way from some sort of acute injury. Okay. And so that's now sensitized that area. So now you also have a quadricep that is wary to pull on that area because it causes pain. You also have a nervous system that's kind of freaked out a little bit about causing damage to the area too. And so you can see how there's layers of things. So now if I just work on, let's just take the simplest exercise of just an isometric load to the anterior knee. What are you treating? Well, you could say you're conditioning the structures underneath it to start to become acclimated to those loads. But you could also be just showing the nervous system that, hey, nothing's getting damaged here. You can actually probably put more force through this than you're willing to. Okay, well, that's not structural. That's getting more towards the other half of things. And then, of course, it could be that the quadricep has become weak because you haven't been using it and putting load through it. But you can't really know that because you can't test the quadricep without putting load through the patella. So you can see how there's this kind of stew there of questions. And so are you strengthening the quadricep? It's like, well, maybe. Are you conditioning the patellofemoral joint? Maybe. Are you working on their fear or on their sensitivity? Just that they're sensitive, which is driven by fear and anxiety and all these other things. And so there's all these things that you could be treating. And so kind of playing with your interventions a little bit to get this feedback to say, okay, what is it about this intervention that's making it most effective for this individual here? That's important to understand and to think through that. And so what you'll notice, what I'm doing here is basically, and this is the hallmark of science, is I'm trying to generate as many explanations as possible, as many alternative hypotheses that I can then test during my intervention with the individual. So how would we see this? All right, well, if I do an isometric hold for 45 seconds and I do 3 of those, and I tell them just to go to like a 3 or a 4 out of 10 pain, and on every rep, they end up with much more force production than the previous rep. Okay, clearly I'm not changing structure that fast. So what am I actually having an effect on? Oh, well, and this is why I talk about you're kind of calibrating that nervous system to say, this is what you truly can tolerate as far as a load. But that's getting into what kind of fear is associated with this. So how much education do I need to do? Again, how much of this is them intentionally being afraid? And I say intentionally, like they actually can express verbally that they're afraid. And that could be that they are intentionally limiting how much load they're taking, or it could be just a nervous system that's overreactive and it has nothing to do with what they believe or feel. It's just a matter of getting that. And so, playing with those different things of how much education do I need, just how much exposure do I need, how much of just letting them work within some pain, it may actually be useful for this person. This is why science is important, as opposed to saying, I don't know why it works, it just works.
Yeah. This is what drives me crazy about so many of those Instagram videos where someone has shoulder pain and then the physio says, oh, it's because they have a rotator cuff weakness. So they give them 3 rotator cuff exercises and they test them immediately after, and they feel better when they press maybe before and after those different exercises. And then the person will conclude, hey, see, this is why the rotator cuff was weak. And it drives me crazy because I have an Erik in like the back of my head saying, like, hey, what else could be going on here?
That's exactly right. And so that example there is, and this is where, because if you were trying to strengthen the rotator cuff, that's a very specific protocol that you would do for strength training. So you need to be about 70 to 80% of max volitional isometric contraction as far as the intensity. You need to do a certain number of, sets and reps to failure or to an RPE. This is muscle training type systems. But if I'm just trying to get somebody exposed to a load that they think is dangerous, but is not actually dangerous, and I'm just trying to do that, that's an exposure. That's almost a psychological intervention of like graded exposure, graded activity or something like that. That's completely different. Now, your, periodized, 4 sets of 8, because 3 sets of 10 is apparently bad. 4 sets of 8 program may work. And you think because you're doing a strengthening program that it's working because it's strengthening, you're totally kind of wasting your time on your programming because if it's not actually that. And so again, that's where, and you can play with it again, like we were just talking about, you can play with it and see what are all the reasons why this person might be getting better. Because the other thing too is if you believe that they have to get stronger, then technically you need to get them stronger before they are going to feel better and before they are going to be able to be discharged. Mm-hmm. And you could do your testing, and the difference is that the number on your force gauge, whatever gauge you're using, may actually be exactly the same from evaluation to discharge. I would doubt it because pain, a resolution of pain should see a resolution in force production. You see that increase. But a lot of times you'll see there wasn't a change in force production. The change is that they don't hurt when they do it. Mm. And so you didn't get them stronger. You just got them tolerant to the load. But they've always been able to generate that load. And these are the ones, example like that would be someone who has pain, but it's not so much pain that it shuts them down. It's just enough pain that it's annoying. And then you just go ahead and condition them and they no longer, they've become desensitized to the pain. And that's what's making them move forward. But there was no change in force production. Even though you did a strength training program, you actually weren't strength training.
Right. Yeah. So let's say you think that someone truly needs to get stronger in order to get out of pain. I think you have a decent idea of what you would do there, right? You would develop a strengthening program. But if someone had this pain that you felt was more so of a load tolerance issue because their nervous system was sensitive, and again, you give them those 3 sets of isometrics and you see their force production increases from set to set, and you deem that it's potentially related to their nervous system, how does that inform your treatment plan? And what do you do from that point?
Well, let's stay with that example of patellofemoral pain. And actually, shoulder pain would be, as far as I'm concerned, it's essentially the exact same thing that we're talking about here. Usually somebody who's having a lot of difficulty with patellofemoral pain, we do know from the literature that they also have some fear avoidance behavior, anxiety, depression, these types of things kind of layered over it too, which could be what's perpetuating it. For example, how many times does somebody get some anterior knee pain and they just kind of ignore it? They back off on what they're doing. They give it a little time and then they ease back in their activities and everything's fine. And they don't need any formal rehab, quote unquote. So usually there's something that's driving it to the point where they actually come into the clinic with that problem. It's rare that they were like, yeah, this just started 3 days ago. Okay, well, they probably don't need anything. It's usually
I've never seen that.
Exactly. It's usually I've been wrestling with this for a couple months now or even years. And so, okay, well, we have a whole complicated thing that we're dealing with now. All right, so here we go. And so, you get them loading. Now, if they've been dealing with this for a long time and they've been unloading that anterior knee for all that time, I guarantee you their quadricep is actually weak. Okay. It hasn't been taking a load. And so you'll get to the point where you can condition the patellofemoral joint, whether that's physically or, from a fear perspective or from a nervous system perspective. You can get it to tolerate the amount of load that the quadricep can currently put out. And so all of a sudden their pain will go down, and now you're just getting a strength training effect. So now you're working on strength training for that quadricep. But as the quadricep builds up, you might notice that the patellofemoral pain starts to come back because now the quad is putting out more force. And we got to get that patellofemoral joint, somebody who has a history of the problem, they're going to be like really good at feeling that in the future. And so what would just be a normal little discomfort of loading and training could actually be interpreted by this person's brain as pain. And so you got to restart. You're basically now shifting gears. And then all of a sudden, maybe it starts getting some tendon symptoms. Well, yeah, you have a tendon that hasn't been loaded in however long as well. So you see how you're kind of moving around in your treatment of now I'm treating a tendinopathy. Now I'm treating the patellofemoral joint again. Now I'm treating the muscle. As things start to tolerate more load, it kind of moves around a little bit. And I like to have that conversation with, this whole conversation with the patient going into it so that they understand that don't get worried. If it goes away and then kind of comes back, we're very systematically moving this along. And this is where I feel, objective information is extremely useful because get them on a dynamometer, show them their force production, and then they'll see first off how low of force production they have through their extensor mechanism when they start. And then it could be, like I use this as a case study example when I teach of a case that it took her months and months and months, and she was super discouraged. She was doing it all on her own because she had a high deductible with the insurance plan that she was on, and she had already exhausted it because she had just gone through an ACL reconstruction a year and a half prior. And she came back 2 months later and she's like, this isn't working. I'm not feeling any change. And then we actually put her on the dynamometer, and you could see she had doubled her force output. But she was so bad when she first came in, she was like 10% body weight, and you should be 100% body weight. She was like 10%, or I think she was like at 20% body weight. Now she's up at 40% body weight. Well, yeah, 40% body weight still sucks. And you're still not going to notice any functional change because that's still ridiculously low for function. And so when she saw that, instead of demanding that we change the course of action, she realized, oh no, I just need to keep doing what I'm doing and just keep giving it time. And that feedback is huge because that lets them, we talked about that earlier, how important feedback is. And that feedback is accurate and the feedback is objective. And so she's not going to start arguing with me. She's going to look at the readout from the dynamometer and be like, oh yeah, okay, that totally makes sense now. And here we go.
Right. And it's a lot different from using an MMT. So just using your hands to conduct the strength or to assess somebody's strength, which is obviously not objective. It's purely based off of memory when you go see someone 2 months later.
Yeah. And when you talk about a factor of body weight, that's a lot of force. And so even half body weight is going to feel strong in your hand. Because if it's actually body weight, especially if they're bigger than you are, they're going to lift you up off the table, ideally, if they're strong. What are you doing?
So is this body weight is it an isometric at about 90 degrees of knee flexion? How are you doing this?
Oh, so that comes from, so the torque to body weight ratio is at 60 degrees isometric. And it is 3 Newton meters per kilogram of body weight. And so the problem we have is people don't weigh themselves in newtons, first off. So they don't know their weight in newtons. Secondly, Newton meter is a torque. And so the math just kind of doesn't work out at all when you do it in that kind of rating. And again, it's torque to body weight is actually torque to body mass. If we want to get pedantic, the difference between weight and mass, force and mass. But in the imperial units, that actually translates to 1 foot-pound per pound of body weight, which comes in really handy because it basically says you need to take a body weight worth of load on your anterior knee. And so at 60 degrees. And so the analogy would be if I'm if I'm a 150 pound individual, I should be able to bend my knee to 60 degrees, have that, my shin parallel to the force of perpendicular to the force of gravity. So I'll be laying on my back with my shin parallel to the ground with my knee bent at 60 degrees, I should be able to put a 150-pound barbell on my shin, 1 foot down the shin from my knee. That's how that math works out. So that's like a body weight right at that point right there. Now you can imagine how that would feel on your shin. Very uncomfortable. This is why you have to make sure you have adequate padding and an adequate strap when you're testing somebody, because they're going to put that much force through it. And if you use a narrow strap, you're not going to get their peak, because their peak is going to hurt. Right. And so you have to use like a 4-inch strap is what we tend to use. It's a pretty wide strap to distribute that. If you're going to, that's what at those electromechanical dynamometers, like an isokinetic machine, that's what their advantage is a very wide strap with some padding. And so you're going to get these torque lines that are really, really high. And so, obviously that would work the same if you put a kilogram, if you're using kilos, it's the same, because you just convert pounds to kilos. But, 1 foot kilo per kilo of body weight is just not things that are commonly used.
Right. Do you have any resources for people so that they could learn how to set this up? Let's say they don't have an isokinetic machine and they just have, just like a handheld dynamometer, like a Tyndek or something like that. Yeah.
And Tyndek's a great example of that kind of pull dynamometer setup. And that's, we have a study that's in review where we're comparing that to an electromechanical dynamometer, and it wasn't a Tyndek. It was a one of those Mark 10s that's modified as a pull dynamometer, that we use. It's a study out of Liverpool, that showed that, if you have adequate padding, you can get pretty close to what you get on an isokinetic machine. But probably the best resource for that, is Scott Morrison's stuff that he puts out on, it's physiopraxis.co. So not .com, but .co. So all one word, physiopraxis, praxis.co. He's got some videos on there. He's got some on his Instagram account as well, but I think it links back to them from his website. So that's the easiest way to find him. He's got a lot of really good resources on setting that up. Cause that's something that Scott and I worked really hard that's where that Mark 10 comes from. It's modified because of us harassing the company to make the modification, because that crane scale type setup, that pull setup, is you can use adequate padding on it. If you try to use a push dynamometer, there's no way they're going to be comfortable with that little pad from the dynamometer. And so Terry Grindstaff actually showed that you can do it at 90. You put the dynamometer behind the table leg and use a gait belt to strap the dynamometer around the table leg to the person's distal tibia. And that's going to give you a much better number, because that's going to be a whole lot more comfortable. The problem with it is that gait belt is still only, a few inches, like 2 inches in width. And so we find that it's still kind of throttled down from a true measure.
Got it. Okay, cool. I'm definitely going to check that out. So thank you for sharing. I hope everyone else does as well. So we're talking about obviously objective measurements here, and that is within the realm of science. And I am with you. Obviously, I think that's why you're on my podcast today. But I'm going to play devil's advocate here. Some people, they don't really take a ton of objective measurements, some physios, and they get people better, or at least they think they get people better. People, let's say it'd probably be more accurate to say that people get better under their care. And I know that people make the argument that physiotherapy is more of an art than a science, because you're dealing with people and people are complex and there's a lot of emotions involved and everyone's different. So what is your perspective on the statement that, physio is more of an art than a science?
Well, remember what I was talking about before about the patient that comes and walks through your door. They tend to be catastrophizing and some of these other things going on where they're actually more perseverating on their symptoms. They have anxiety, all these other things that are kind of layered onto it. And so when you look at like the psychological interventions for those types of things, I'm a big proponent of, Rogerian psychotherapy, which is from Carl Rogers. Pretty much all like cognitive behavioral therapy, all that stuff is all stemmed out of Carl Rogers' approach to treating patients. And this is the Foundations of Practice course that I have online. It goes into deep dives on Rogerian psychotherapy, some of the weird research that was done around that, where it just shows you just pay attention to somebody and let them talk, and they will feel dramatically better when they walk out the door. You don't have to do anything. And so how much, when you think about how a lot of these physical therapists are practicing, they are a sympathetic ear. They validate the person's concerns. They don't judge the patient for those concerns. They give them physical contact. We are social creatures that enjoy that physical contact. The person just feels a sense of well-being that it's almost more of a psychological intervention. And so there they go kind of on their way from that. And that's where, the question is, what is this person trying to get back to? Now, if they're just trying to get back to, their daily life and it's just that kind of mental spiraling, which is what's setting them off, you may have just treated that. Now, the problem is you probably didn't intentionally treat that. You thought you were like realigning their patella, or you were, all these other things that we think we're doing. When it's like, no, all you did is provide a compassionate ear. And that, help the person kind of get past that, but it didn't necessarily, that again, and that's fine if they're just trying to get back to, going for a walk, going up and down stairs, maybe, interacting with their grandkids or something like that. But if you're dealing like with an athlete who's trying to get back to a high level of load, there's that bridge that you have to be able to kind of take from there. And so we even see this with really high level athletes. The big problem that they have is, as a high level athlete, they're extremely skilled at adaptation. And so you could just rest that patellofemoral pain or patellar tendinopathy, for example. You just rest it until it feels better. They actually don't have their load tolerance is not any better. They just stop loading it. And then as they gradually return, they may not gradually load that area. They may just learn, oh, I can just make a modification to how I do things, and now I don't hurt there anymore because I just stopped loading it. And that's fine, because functionally they'll get out there and they'll do their thing, but now they're missing something that they used to have. And this is what we see with these higher level athletes, is they'll do that with 3 or 4 injuries. And now what are you dealing with? You have this kind of stack of limitations that they're dealing with, and their sport kind of falls apart. Their ability to play their sport kind of falls apart. And so that's a lot of the work I do now is, we'll pick them up and be like, all right, well, you have this old patellar tendinopathy. You generate like half the torque on that side than you do on the other side. You also have this old like Jones fracture. And so when we test your everter strength on that side, it's also garbage compared to the good side. You have a groin injury on that side as well. We look at your adductor force production, and it's crap compared to the other side. And so it's not even a matter of like trying to blame these things for their problems. Just like, hey, let's just restore these things, your load tolerance in these areas, and then we'll put you back out there and see how you do now. And what they talk about, there's no neuromuscular training or any of that kind of stuff. You just bring their forces back and then put them back out there, and they're like, oh wow, I feel like I have another gear, or I feel like I can do things that I haven't been able to do for 5 years. It's like, yeah, you just took that part of your game away. And so we're trying to give it back to you. But again, when we're talking about the amounts of force that the human body can generate and can tolerate, it's way higher than we expect. And so you have to have objective data to actually, first off, detect it, and then be able to track it and watch it change. But I totally agree because some people are like, what's the best training for running? Well, go run. And yeah, if that's all you're trying to do and you're just recreationally, out there, that's fine. You might want to do a little resistance training to kind of elevate your load tolerance a little higher than the day-to-day running, so that when you have like you step on a hole or step off a curb without realizing it, that little spike of load doesn't, you're less likely to get injured is the idea there if you have a little extra load tolerance. But it's also a matter, and I'm real big on this, how much do you care? Because some people are like, I don't want to do all that work just to kind of protect myself. I'll just deal with the injury when it comes. It's like, that's fine. That's your choice. We all get to make these decisions. So yeah.
Right. Yeah. Which I always love that perspective, because I think a lot of physios have the bias that that's not okay, and
I
that we
know,
should
it's
all,
amazing.
yeah. And that, although people are free to make their own decisions, I think a lot of
Yeah.
us would say, but that's a terrible idea.
Well, this is, we deal with this with athletes. So like, well, I kind of just want a massage for this. It's like, well, you can go get a massage for it. It's just, don't believe it's fixing anything. It just, but there's nothing wrong with doing that.
Yeah.
The other thing is you get these patients that'll, let's say they have a tendinopathy and you give them a loading program and their tendinopathy starts feeling a whole lot better and they're doing it all. And you're like, oh, you know what to do. Keep doing it. And so they go do it and you'll like run into them like 6 months later. And hey, how's that tendon doing? It's definitely better, but I kind of stopped doing the exercises, and went back to my thing and it kind of hurts. And, when it gets really bad, I do the exercises again. And then when it feels better, I stop. And I know I should just keep doing the exercise and really fix it. It's like, well, why? Obviously the exercises got you to the point where you're able to do your thing with tolerable pain, which is all you were looking for. The exercise is just a tool and you use it to the extent you want to use it. There's no shame or harm in that. I mean, you got a life outside of this, don't you? Do you really want to be spending all that time doing these exercises to quote unquote permanently fix it? I can't even guarantee it would permanently fix it. It could just be keeping things at bay and that's all it's there for. And that's all it's needed. As long as you're doing your thing and you're happy, then do it. This is, when the patient comes in and says, I have this thing, and you're like, all right, well, here are the exercises, and they do them for a while, and then they come back in when they stop doing the exercise, say it hurts again. It's like, well, yeah, you're not doing that thing that was working for you. You should just go back to doing those. Like, yeah, but I don't really want to do those. I don't want to do any of the treatments you're offering other than some passive stuff that just kind of feel good. It's like, okay, well, then stop complaining about your pain.
Right.
We deal with athletes all the time. It's like they'll say something hurts, but they don't want to get pulled out of the game or out of play or practice. They don't want to do any treatment for it. It's like, well, then stop talking about it. Because why are you talking about it and then you just want some sympathy? I mean, I can give you that, but you don't want anything else. And that's cool. That's your choice. But yeah.
I think there's the idea there that there are other treatments out there that would really work well for them. Like, someone does have the magic massage abilities to cure their issue.
Yeah. And I'm always really big on helping them find those resources. Yeah, hey, go do that. I've had cases, in all my years of practice where I'll have a case where it's like, all right, well, here's what I can do for you. We can work on this, that. And they decide that they don't want that. They're going to go do something else. And it's like, cool. Yeah, go work with somebody else and they see somebody else and like, oh, this person's really, they really dialed in that my hips are out of alignment and that I need, this and that kind of work. And it's like, okay, yeah, go do that. And then like 2 years later, they come through my door again. And they're like, I'm still having the problem after doing, I've actually bounced around to 3 other providers. And after thinking about everything, I kind of understand what you're saying now. It's like, yeah, this is, you have a low tolerance issue. Let's address it head on. And then you have the buy-in, but you'll notice is that I couldn't force that. Yeah. They have to come to their own conclusions on that. And that, again, that is a Rogerian approach, but that's also just good old classic Socrates. You can't teach anybody anything. You can just kind of show them information and then they have to come to their own conclusions about how the world works. But you can't force them to understand it the way you do.
Right. And there's no need to.
No.
Yeah. We all.
Hey, I mean, we're all wrong about things all the time, and we're all ignorant on things. You can't be an expert on everything all the time. And so, I've that's something I think I've mellowed up about as I get older, is like, it's perfectly fine for people to be wrong. I don't need to change that. You
Yeah.
know, how can I help this person? And oftentimes, you know, I've definitely have interactions with athletes where their head is in a completely different space than where I'm trying to get them. And I can't just pluck their head off and put it in a different spot. I have to meet them where they are and then see how far we get. This is something I harp on too with, and it's really true with high level athletes, is that their lives are chaos and they are torn so many different ways that, yeah, I could have a perfect plan in my head as to what to do for them. There's no way in hell that's going to be executed. So I have to figure out what are the little things I can do for this person to help kind of nudge them in the right direction and help them find ways that they're managing well and successfully. You know, what's the least I can do for them to give them the best, you know, that kind of 80-20 rule of what's the 20% of work I can do to get 80% of the results, whether that's a real thing or not. But it's that concept is something that, you know, I'm always harping on professionals for that, because I'll watch them. They get started down like these 40 other interventions that it's like, yeah, maybe those will do something, but they're not going to do much. And so, and then you're mad because the athlete had to go because the agent's calling them and because their spouse is dealing with the kids, needs help, and, you know, this, that. And it's like, this is no fault of that athlete that they can't commit to your program, but that's a cop out when you say, well, they're not committed to my program, that's why it's not working. It's like, no, you need to work with them.
Right. Yeah. I've had a couple of students shadow me in the clinic, and they'll say, you know, do I get mad when patients don't do their exercises? And I always tell them, no, it's immediately, it's always an opportunity to take accountability and to work with the person a little bit more and
Yes.
try and figure out, you know, why they aren't getting done. Is there anything that I can do to help?
Yeah. Well, that gets back to the scientific perspective of, you got efficacy and you have effectiveness. So your program may be efficacious, meaning that if they did it perfectly, it would work, but it's not effective because they can't commit to it. And so that's not their fault. That's your program's fault for not being effective. And so you have to find a way to make it effective. So again, the difference there, efficacy is that it works in a perfect situation, like in a lab environment. Effective means it works in the real world. And so you hear people always, you know, complaining about these injury prevention programs, like there's the 11 plus, the PEP program, all these different programs for ACL injury prevention. And the big complaint is that they don't work and it's strictly because the coaches won't implement it. It's like, if the coaches refuse to implement it, it means your program is not effective. You need to find a way to make it effective. So why do these coaches not want to do it? Well, because and I hear this feedback from coaches and athletes. Well, it seems like pardon my French, a bunch of bullshit exercises. It's like, yeah, because a lot of them are loaded with exercises that are probably not helping. And so you got to figure out what are the 2 or 3 exercises of this vast program that are having the biggest result. Focus on those couple things and you'll see compliance go way up. Now, it may not be the perfect, most efficacious program, but it may be a whole lot more effective because of how you're implementing it. And so that's the same thing in the clinic when you're working, you know, one-on-one with the patient is, how do I make the most effective program for this individual here, which is going to be very much tailored to them.
Yeah, a lot of the time I think people go along the efficacious route and they try and create like the most perfect program.
Yep.
If it was to get done, it would be the perfect program.
Right. And then they blame the patient for why it's not working. And
yeah,
so
meanwhile, it's 15 exercises long.
Exactly. Yeah. And it's supposed to be done twice a day. And it's like, what? Are you serious? I mean, and first off, I have my doubts that it's the perfect program. And then secondly, there's no way it'll be effective unless the patient has so much buy-in. And this is the problem we have with the compliance stuff is, you know, let's say I have patellofemoral pain, which we know natural history regression to the mean is going to start feeling better. So there's a subset of people that are just going to start feeling better. And so if you give everybody this program, the ones who are starting to feel better for whatever reason are going to blame the program. They're going to keep doing the program because they think it's working. And so their compliance is going to go up. And so you're going to have a correlation between people who are doing well with people who are compliant. Guess what's going to happen to those people who've been doing your program for 2 weeks and their knee is not feeling any better, regardless of why it's not feeling any better. They're going to tend to stop doing your program because their knee is not feeling better. And so you're going to have a correlation of people who are non-compliant are not doing as well. And so then your conclusion is compliance is the thing that needs to happen, when it actually may have nothing to do with the actual effects of what the person is seeing. Meaning your program may be doing literally nothing. And the fact that they're compliant is just a reflection of the fact that their knee is feeling better. So your causal arrow, so what's causing what is actually backward. Feeling better is making them more compliant. Not more compliant is making them feel better.
Right. That's so interesting. Okay, so this goes into an area that I wanted to chat about with you. And this is sort of a way of critical thinking where it can help you just reflect on practice a little bit more, and I think overall make better decisions. And I think that comes from, just a scientific mindset. And I think a lot of the time what comes to mind when people are evidence-based, or what comes to mind when they think people are evidence-based, is like they're reading tons and tons of literature and they're staying very up to date. And, I think that's a part of it. But we all know that some clinicians just won't find the time. Yeah. Again, maybe it's an efficacious way to go about being evidence-based, but it's not the most effective one to read all the new research. So yeah. I wanted to ask you, are there any, principles or tools for critical thinking that you would recommend to people so that they can make better decisions in the clinic? And one example here, I've heard you say this in the past, would be sometimes when you are trying to change someone's mind, you ask the question, how confident are you? And if they're not 100% confident, that means that they're willing to potentially change their mind. And I have taken that and I ask myself that now. Yep. Like if I think something, how confident am I in that? Yep. And if I'm not 100% confident, that means there's potentially other explanations. So are there maybe any other tools, or maybe you want to elaborate on that one a little bit more? Yeah, so that's it's a two-part question. The first question is, how confident are you on your opinion on something? So how likely is it that you're right? Mm-hmm. And so if they give you any number other than 100%, it means that there is a possibility that they are agreeing that there's a possibility that they're wrong. So then the next question is, what would it take to prove to you that you're wrong? Like, what evidence would you need to see? What would it look like? The evidence that would make you change your mind. They should not be dumbfounded by that, nor should you. You should be able to lay out exactly what I would need to see in order to make me change my mind and believe the opposite or just something different. And so that's one of those things that it's kind of like a mental exercise that you can do. And the simple thing is, you should never answer 100%. Therefore, that first question doesn't need to be asked when you're asking yourself. So the second question of what would it do? What would you need to change your mind? What would you need to see? That's the next thing. And so the problem we have is we tend to use confirmation bias, which is, what would I need to see to keep believing what I'm believing? No. What would you need to see to change your mind? So now looking for contradictory evidence to what you're saying. The other thing I strongly recommend people do is, when you have a belief, which we all do. So let's say you do an intervention in the clinic, you're immediately going to get, your brain's going to go somewhere to explain what you just saw. That's just human nature. It's what you're going to do. And so what you need to do is just take a step back immediately and say, how else could I explain what I just saw? Because the problem we have is, when you come up with an idea, like when you come up with an explanation, there's a lot of reasons your brain went to where it went to. Biased, your upbringing, your tribe, so to speak, of, how do you define yourself? You'll notice all these revolve around identity. So what's happened is that your explanation is tied to your identity. So if your explanation gets refuted, it's like an attack on your own identity, and that is not comfortable. And so what I recommend people to do is, instead of
letting your brain just do that. I mean, let it do that, but then immediately think of all the other ways you can explain it, because as you think of other ways to explain it, you own all those other explanations. And so it actually softens your, certainty and your identity attachment to the original explanation. And it lets you be a little more open-minded to move to, because it allows you to say, oh yeah, I thought of that. I thought of this other reason. And the cool thing is, this is what I do all the time. And the cool thing is a lot of times, and get creative and think of all sorts of wild explanations. I've thought of wild explanations and kind of chuckled as how absurd it is. And then thought for a second, like, actually, hold on a second. That kind of fits a lot of, because we have a lot of paradoxes where it's like, well, it's explained this way, and they're like opposite. And then you'll find that there's a third explanation that actually resolves the paradox. It kind of reconciles it. And so it's actually that is more likely, because you see these two directions that they refute each other, but there's a third one that accepts both directions. Example would be, we know that strength training, so doing resistance training as a program for an athlete is going to reduce their injury risk. So they'll have less injuries if they do strength training. However, strength itself is not protective, meaning athletes who are stronger don't necessarily have a lower incidence of injury. And so that's a paradox where you're like, but I thought the strength training, it's like, well, therefore the strength training is doing something else. Mm-hmm. And so the explanation I like to give is, well, if you think about it, when you're doing strength training in a weight room, you're actually getting reps of exposure to your body interacting with high loads. So whether you can interact with high loads, your body doesn't get the feedback reconfirming that it can interact with high loads. So it may not actually use that in a high stress situation. But if you have experience with knowing where your boundaries are and knowing what your force tolerances are, that tends to kind of, the idea here is that would expand the bubble, so to speak. So that explains both, where just having the strength doesn't matter, but the resistance training is doing something beyond just building more strength. It's actually just exposing to more reps of, I know what to do when presented with high load because I do it all the time in the weight room. And so that's an example of this third explanation that reconciles these two truths that we see in the literature.
Cool. I wanted to go into another example with you. Do you have time for one last question
sure.
here?
Yeah.
Cool. So without having looked at the literature yet, which, I know you have on this, because it's an area that maybe potentially, I'm pretty sure. It's an area that I know is an interest of yours. Let's say someone makes the claim that leg extensions are not good for people after they had an ACL surgery or with an ACL injury. Before looking at the literature, what does your mind do when it comes to approaching that claim?
Well, first you have to explain why you would think that. Mm-hmm. And so the idea there, and it's actually a little counterintuitive as to why you would think that leg extensions would be dangerous on an ACL graft.
I guess the idea a lot of the time is it puts too much stress on the graft.
Correct. But, if you really think about okay, well, how? Well, you have to use these biomechanical models to actually show how that graft is getting stressed. And so there's a lot of modeling is where that comes from. That when you get between 40 and 0 degrees, that the quadricep can create an anterior shear on the tibia and therefore put stress onto the graft. All the while forgetting that we do a Lockman on these people all the time, which is exactly that. But that's the explanation. So it's like, oh, well, this is going on, so we need to be careful of that. Well, first off, that's just using biomechanical modeling. Now, when they have done this research where they do in vivo force transducers. So what they did was when they had these patients who were getting a meniscus procedure, and they gave him local anesthesia. So just they numbed the knee up, but the patient was awake. And while they had the tools in there, they went ahead and put a little transducer with a little, I think back then when they did it, they had a wire coming out that actually had a force gauge on the ACL. And then they had the patient get up off the table, the OR table, do a squat, see how much force went through it, had them do a leg extension with no weight. Unfortunately, it would have been good to have it weight, because they did a squat with no weight and a squat with using elastic bands to add resistance. And then they had them seated doing a leg extension. And then they did a Lockman as their kind of reference point. And I think the strain from the leg extension was 4% of what you get on a Lockman. And
4%.
a squat with resistance was 6% of what you get with a. And so the thing was, it just didn't hold up. But again, this was unloaded. And so that's the thing is, okay, well, you put a load on it. Now the quad's going to have to pull harder. Maybe that's going to put some strain. So that author was Beynon, Beyonn, I believe. And I want to say it was late 90s is when they did that. So this is not new research. But again, the counter argument is, well, but what about if you put a load on it? It's like, okay, so now let's take another step back here and just think, what is pulling on the graft? Like, what's pulling on the tibia? Well, the quadricep. The weak ass quadricep that can barely engage after surgery. You're worried about that causing harm to a graft fixation that is fixated. I mean, if you see the surgery, that graft is in there. So the idea that it's going to make the fixation fail, because it's not going to stretch the graft out. The graft can take, depending on what graft they use, is anywhere from like 200 to 400% of the tensile strength of the native ACL. You ain't hurting that graft. Now that changes as they go through the remodeling process, that it's not going to be superhuman load tolerance anymore. The body's going to adapt to the loads it needs. But you're not going to damage the graft like that. It's a fixation that potentially you're going to start pulling the graft out of the tunnel. That's the idea here of what. But you know how much load that would take to do that? When you're working on like terminal knee extension, like range of motion, you're putting some stress on that. Just walking puts some stress on that. And there's follow-up studies that have looked at that. But, I guess maybe if you're worried, and probably the best article to read on that is it's called Who's Afraid of the Big Bad Wolf? And it's a commentary by, I forget the lead author now, but Lynn Snyder-Mackler is on it. So you can just look up her work. And she's been a big proponent of doing leg extensions because they're super important, because what we know is if you don't have a quadricep, you're going to find a way out around the quadricep. Yeah. And a leg extension isolates the quadricep. That's all it does. That's what makes it special. But so people are like, oh, so it's perfectly safe to go from 40 to 0. I'm like, yeah, it is. But I will also flip that and say, you probably don't need to be going from 40 to 0, because also that's a mechanical disadvantage position for the quadricep that you're not going to get all that much force production up there anyway. So what are you working on? I usually tell people do a partial arc leg extension, because you're going to get you're going to be able to work with a much higher weight, and that's going to get you more. So we limit it to only going to about 60 degrees and then bend as far as they feel comfortable and just do that arc. You're going to get way bigger quad burn doing that than going all the way to terminal extension. So I don't see a great use for going to terminal extension on a leg extension machine, because that's not how the quad does not produce, look at force position curves. The quad does not produce a lot of force up there, whether you're squatting, doing a leg extension, doing a change of direction. Nobody locks their knee out straight to do a change of direction. They bend past 45 degrees typically. So that's where the load hits them. And so, to me, it's just kind of a waste of time to be up there.
Interesting. So it's not necessarily that it's, a waste of time to work on getting full extension, but maybe on a leg extension machine, that's not necessarily the most appropriate time to do so.
No, I mean, full extension range of motion wise, yes, let's get all that back. Having the ability to do a quad set or a straight leg raise, yeah. But loaded up there, I mean, what are you doing? You're doing an isometric with the muscle at full contraction. Who does that? What other joint? Like if you wanted to work on your bicep, You're not going to bend it to terminal flexion and then do isometrics there. That's silly.
Yeah.
You're like, well, yeah, but it feels really weak. And so that's what people say, like with a quad. Well, if it feels super, like it feels like I have to work really, really hard to engage the muscle up there. And so therefore it must be, it's like, okay, so you have a really strong neural drive, but you're not actually putting any real load to anything. This, again, put your bicep at terminal flexion and then engage. You're going to feel like, yeah, I have to like really focus and drive hard mentally to try to generate any sort of force there. It's like, yeah, because it's at a mechanical disadvantage. What are you doing?
Right.
You would train, if you wanted to train biceps isometrically, you'd put it at the mid range. So why do we train the quadricep at end range, contraction? People say, oh, well, because, with walking, it's like, what? You think your quadricep is that engaged when you're at terminal extension when you're walking? Yeah. It's barely taking a load. It doesn't take a load until you get to about 45 to 50 degrees of flexion. Then that's where the quad hits in. It becomes a big mover. So, yeah, again, when you really step back and think about it from just basic principles, a lot of these beliefs become really absurd and kind of nonsensical. And this is where, I'm a big proponent of, just dumb it down. Why you way over here? Just go back to really basic foundational concepts. That's why I teach basic physics, force time, force position, impulse, looking at how these things interact with each other to, force equals mass times acceleration. What does that mean? It means that if you want to increase force on somebody, we'll increase mass. No duh. We put weight. You work with weight. But there's another part of that equation, meaning the acceleration part. So if I want to add force, I can also add speed. And not just speed would be the velocity, but the change of speed. So how quickly do you do a deceleration or an acceleration? That creates forces. And so, you look at like a tendinopathy, it's that plyometric. It's that real quick change of momentum that creates your spike of force. Well, that's very chaotic to try to go at that directly as part of your rehab with some of the painful tendon. That's why we manipulate the mass side of the equation to go very heavy isometrics, because isometrics allow us to go to a much higher intensity than even a concentric. But we can, if we're going to do concentric eccentric, we're going to go super heavy, because that's going to give us a force that's going to match what they experience with a high acceleration task. But I have easy way to control that. But this is just foundation. I'm literally just manipulating Newton's second law that force equals mass times acceleration. That is all I'm doing. And of course, when I'm teaching this at a conference or something, it's like, they're like, we need to cite 5 citations in the last 5 years. I'm like, well, here's Newton's Principia from 1687, and this is what we're going to use. I'm sorry, I'm not evidence-based, but I'm just using basic physics. And this is the thing that frustrates me, is then somebody will bring a study that's like some randomized controlled trial that's way underpowered, horribly biased in the way it's set up, and they're going to claim that that's why they're using lasers. I'm like, well, lasers defies Isaac Newton's basic principles. So
how so? I've heard you say this before, but I don't think I've ever heard you dive into it.
Yeah. So first, when people are talking about using lasers, my first question is, why do I need to use a laser? They're like, well, because of photobiomodulation. It's like, no. I understand all of that. Why a laser and not a flashlight? And usually that breaks their brain, because they actually don't know the difference between a laser and a flashlight. Okay. And so what makes a laser, there's 2 things it does. One is that it can narrow and concentrate the light into an extremely narrow beam. Now, why would you want to do that? Well, by concentrating light, which is energy, you are able to generate a lot of energy in a very small space. And that's why they use it medically for cutting. Well, clearly we're not using it for cutting, because that's a laser can cut by concentrating its energy and to be able to cut and cauterize at the same time. So it's a high temperature cut. And so, yeah, great tool for that. So clearly we're not using it for that. So then we'd have to be using it for the other thing, which is that you can get a concentrated wavelength, meaning I want a specific wavelength of light, and wavelength would be color, because that wavelength is important. Okay. And so the example you would give is, for example, plants use a specific wavelength of light for them to do photosynthesis. This is your photobiomodulation, or PBM, you'll hear them refer to. It's like, great. No, I get that. But you do notice that we don't have to shine that specific wavelength of light and that specific wavelength only of light on a plant for it to do its thing. So again, whatever wavelength you want is in the light of a flashlight. So just shine the flashlight on them.
Right.
The body is going to dump away the other wavelengths that it doesn't use, and it's going to reflect it. That's what gives you your color, is the light that you're reflecting back. So the one color that plants don't use is green. That's why you see green reflected back to you. They're using the other wavelengths of light. You can shine anything. You can shine light without green in it, and the plant's going to do just fine. It's not going to notice the difference because it reflects green. Of course, the plant is going to look like gray and ashen when you shine that light on it because there's no light reflecting back. So again, this is just basic principles of light. And so again, explain to me why you need to shine just that wavelength. Not that that wavelength is important, but why just that wavelength and no other wavelength? That's the simple question around using lasers. And so as you should be noticing, just that question starts to seem absurd. That the body would need, it's like that somehow the other wavelengths are causing harm and negating the effects. So I'm not saying light therapy wouldn't be, I mean, we know that from like go out into the sun and your body is going to use that sunlight to generate vitamin D. Yeah, it's a thing, but the sun's not like just shining the one wavelength, the one frequency of wavelength that does that. It shines it all and your body knows what to do with it. Yeah. Right. And so that's why I keep saying, why specifically a laser, other than the placebo effect of a laser is going to be much better than you just breaking a flashlight out and shining on somebody's
it's going to be a lot better.
Exactly. So they're going to report that it's, especially if they have a lot of buy-in, all of a sudden all of our 9 specific effects come charging in with that. And so, and actually a lot of those quote lasers are actually just LEDs, because LEDs, light emitting diodes can be fairly good with the wavelength thing. And so, so immediately you're already away from lasers. You're on an LED, and you could also just put a filter on your flashlight, which is probably LED nowadays anyway. So
that's hilarious.
Yeah.
Okay, perfect. That was a good breakdown. Cool. I think that's a good summary of, why it's important to think about why we're doing things, and really assuming that we're ignorant to a lot and that we don't have all the answers, and that there's usually another way to explain something, or at least another idea to entertain. Well, not just one, but many. So thank you for sharing that.
Yep. Yeah, of course.
Cool, Erik. I really appreciate it. It was such a pleasure talking to you. I learned a lot. I feel like I've heard you say similar things before on a podcast, but for some reason, today felt a little bit different, where I learned a ton from you, and I hope everyone listening had the same experience. So once again, thank you very much.
Yeah, no problem at all. And I get that a lot, where people say that, they'll come to my course and they'll say, I learned a lot. I thought it was great. And then like a year later, they'll come again. And after the second time, they're like, well, it's funny is it really is the same as what you talked about last time, but I'm realizing that there was another level to it. And I learned something different this second time through. And so that's why with the online courses that I offer, we give them 6 months that they can watch it as many times as they want. And so kind of go back through it a few times. And again, I'm trying to teach at a level where even if you don't know anything about what I'm talking about, you're going to get something out of it. But if you do know what I'm talking about, you're going to see kind of another level to it. So like you said, you've heard me say these things before, but it's like how it clicks together. It's like, because it's always going back to foundational concepts and realizing that they actually click together very, almost like atoms in a molecule, so to speak. It's like, well, you can arrange them this way, and you kind of click over here and like, oh, here's a truth. And then you go over here. It's like, oh, here's another truth, or at least it predicts a truth. And then when I can play with testing whether that holds up, and then what other ways could these things click together. And so, yeah, I'm a big proponent of kind of playing around with ideas.
Cool. Yeah. Is there anywhere else that people can catch you? So you have your courses, you have pretty soon to come a pilot course as well.
Yeah, that'll be on a different platform, different website.
Yeah. Okay. I won't be on the Science PT one.
Yeah. And so, I mean, just go to it's thesciencept.com, and pretty much everything is there, and all the links to everything else, is through that. I have social media accounts, on Instagram and on, Twitter, or whatever that's called now, but I'm not on there all that much, anymore, just because as a medium, it's not, I'm more of a long form kind of guy. And so often when I'm on those platforms, I'm more kind of screwing around than anything else. Just things that I find entertaining and poking at. And just, I like watching what, kind of the younger folk are doing now with some of these ideas and education, but it's not really my space. We talked about, podcast I used to do, it's PT Inquest, and it's not that it stopped, it's that I turned it over to 3 other people that are a lot younger and bringing their own views and ideas to it. And I love to see that, and love to see people like you kind of occupying the space and having these conversations and kind of carrying it forward. Because, if I'm the only one talking about these things and then I go away, I want to make sure that these conversations keep happening. Because it's not that when you look at all of human history, we make all the same mistakes generation after generation. And
Right.
that's because we're human, and that we come into this world with these preconceived notions and these ways that our brain works that limits us. And we have to learn the lessons. Every generation has to learn the lessons all over again. And so I don't get frustrated that I keep kind of saying the same things over and over again over the years. It's like, no, I mean, literally read Socrates, read Plato's descriptions of Socrates, read Aristotle. There's the logical fallacies were written by Aristotle, and we all learn them all anew every generation. You have to learn it as you come up. I wish we taught it more formally that people would get it earlier. But yeah, it's Aristotle's organon. They're all there. They're, correlation doesn't equal causation. All these are ancient, thousands and thousands of years old. And we're trying to learn things that are beyond just the basics. And so, yeah. I'm real big on, keep repeating yourself and keep helping other generations learn these lessons as early as they can, so that they can truly move forward, and be better than the previous one. Yeah.
And you were saying that you like to pass on the torch, and you pass on PT Inquest. So, thanks for, I guess, setting the stage originally, in 2011 for this whole podcasting platform when it comes to PTs. And yeah, I was going to say, if people also want to listen to more of you as well, I mean, there's countless hours of you on the PT Inquest from the past before you pass it over to.
It'll always be there. I think there's 300 some odd episodes with me on it. That, going back all the way to there, it's not like I've sat down and listened to the whole catalog since recently. But I would imagine it all holds up pretty well. Even if you started from the beginning, because it's always been this conversation we're having here, where we're just pulling things apart and asking questions, not necessarily having great answers other than here's how we understand it as of right now, and explain it like that. And honestly, I don't see anything like earth shaking to have changed, since we started that. So I would imagine it holds up pretty well.
Yeah, I think so. I mean, I haven't gone back that far, but from what I've listened, it holds up.
Yeah, I can't imagine that's got to be pretty torturous to start at the beginning and listen to us fumbling around trying to figure out how to do a podcast. Those episodes are definitely out there, but yeah, probably pretty terrible.
It's not so bad. All right, Erik, cool. Any final comments at all?
No, I mean, I'm just really big on work your brain. It's a muscle that you got to exercise. And so play around with thought experiments and just play around with challenging some ideas and go, well, what if it wasn't that? What if it was something else? What else could it be? And that's just a game to play. And, the more ideas you have, the more bad ideas you'll have, but also the more good ones you'll stumble upon that you wouldn't have considered, before. So that's really kind of my parting thing. I'm not trying to change the profession. I'm trying to corrupt the youth. That's what I say all the time.
It's such good advice though, because coming from the perspective of someone who used to think that he has all of the answers, and now realizing that I don't, and that, it's nice to be in a position where I'm not having my identity tied to all these answers. Like you were saying before, It's really a liberating place to be. So if anyone still feels stuck in this position where their identity is tied to everything, just again ask, is there anything else that's going on here? Are there other ways to explain this?
And what I would say to the students is, I get it, because you're trying to pass an exam right now. You're trying to pass a board certification, for example, a licensure exam, something like that. You have to stick these ideas in your head so you can answer those questions. And so as I'm sitting here, with the voice off your shoulder telling you that might not be true, that's not helping you. And so I get it. And so maybe it's a thing that you kind of shelve this for a bit and you come back to it later once you get past your classes, your exams. Just be not just learning those things, but also working that critical thinking muscle so that you can be able to work it. Because otherwise you're going to be sitting there taking your licensure exam, like arguing with the test, which is what I always did. So,
yeah. Yeah, me too. Okay, cool. All right, Eric, thanks again.
All right, thanks.
Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.